In this lecture, we are going to discuss COPD, or chronic obstructive pulmonary disease, which I'm sure many of you have heard of before, the different types of COPD, signs and symptoms, and treatments. Chronic obstructive pulmonary disease, or COPD, is a preventable and treatable, slowly progressive respiratory disease of airflow obstruction involving the airways, pulmonary parenchyma, or both. The parenchyma includes any form of lung tissue, which includes the bronchioles, bronchi, blood vessels, and alveoli. The airflow limitation or obstruction in COPD is not fully reversible. So once you start down this path of COPD, there is no going back. You want to slow it down. Most patients with COPD are going to present with overlapping signs and symptoms of emphysema and chronic bronchitis, which are the two different classifications of COPD. And as you can also see from some of the numbers reported by the CDC within 2017 and 2019, a large number of Americans live with COPD currently. What was also interesting about this is that this is just the reported number of patients diagnosed with COPD. There are still believed to be a large number of patients out there who are undiagnosed with COPD and not being treated. But many people die a year from COPD. So in COPD, the airflow limitation is both progressive and associated with the lungs' abnormal inflammatory response to noxious particles or gases, so irritants. The inflammatory response occurs throughout the airways, lungs, and pulmonary vasculature. Some of these irritants commonly include smoking cigarettes, air pollution, and even a genetic component such as the alpha-1 antitrypsin deficiency, which we'll talk about a little bit later. But this is a nice table and pathway that shows how some of these pathogens can contribute to COPD development. COPD has a long, long list of clinical manifestations and what that looks like in each patient. I'm not going to read this verbatim, but please read over it and familiarize yourself with these different clinical manifestations. Quite often, these will be seen in both different types of classification, whether it's chronic bronchitis or emphysema, but they are all very common signs and symptoms. So when you see 2 or 3 or 4 of these in your patient, it's easy for you to go ahead and say that patient has COPD.
Chronic bronchitis is a long-term inflammation of the bronchi. It's common among smokers. People with chronic bronchitis tend to get lung infections a lot easier than people who don't. They also have episodes of acute bronchitis when symptoms are worse. The other one is emphysema. And the main cause of emphysema is long-term exposure to airborne irritants such as tobacco smoke, marijuana smoke, and air pollution. So although both of these patients, smoking is a huge indicator that they're going to develop COPD, we do tend to see smoking a little bit more frequently with the chronic bronchitis, although it definitely can happen with emphysema as well.
So the first classification of COPD that we're going to talk about is chronic bronchitis. And when chronic bronchitis occurs, the bronchus becomes narrowed and causes impaired airflow due to constant inflammation, excess mucus production, and smooth muscle constriction. You can see that pretty heavily here between the two pictures on the different airways. So in many cases, smoke or another environmental pollutant will irritate these airways, resulting in inflammation and hypersecretion of the mucus. So when these bronchial walls become thickened, then this further narrowing of the bronchial lumen will occur. Any alveoli that are adjacent to these bronchioles may become damaged and fibrosed, so they become very hardened, resulting in altered function, impaired gas exchange, and even causing the patient to become more susceptible to respiratory infections. So these patients have been exposed to some sort of chronic irritant for such a long period of time. Their bronchioles are constantly inflamed, and after a long period of time, eventually those bronchioles become stiffened, fibrotic, and then they also start to affect the alveoli near them as well. So when these patients also tend to have exacerbations is going to be during the winter time. The cold air and then also viral and bacterial infections tend to be more prevalent around them as well. So here we have a nice picture of a patient with chronic bronchitis. We refer to this as the blue bloater. So chronic bronchitis patients, think blue bloater. These patients quite frequently come in with a dusky color or appearance to them due to cyanosis. They are going to be coming in coughing with sputum production due to all the mucus that's being produced in the bronchioles. Their oxygen level is going to be low. They're edematous. They have an increased respiratory rate, exertional dyspnea, so even getting up and walking to the restroom could wipe them out. These patients also are going to have a very high incidence in heavy cigarette smoking. So these are the ones that when you ask them about their smoking history, they're telling you they have been smoking for 30, 40, 50 years. Some of them even telling you they have no intention of stopping. You'll see some digital clubbing in these patients as well. And I've got a picture of that a little bit later, so you've got an idea of what that looks like. Cardiac enlargement due to the stress on the heart. From the COPD, you're going to have a lot of accessory muscle usage to breathe. And then also cor pulmonale. So cor pulmonale is a condition that causes the right side of the heart to fail. You get long-term high blood pressure in the arteries of the lung, and then that backs up onto the right ventricle of the heart, leading to cor pulmonale. Now, please keep in mind that the number one leading cause of right-sided heart failure is actually left-sided heart failure. So I don't want you to mix that up with your heart failure lecture. However, if right-sided heart failure does occur during COPD due to the high blood pressure in the arteries of the lung that backs up into the right side of the heart, that is when we classify that as cor pulmonale. Okay. These patients also are going to hold on to their CO2 and become very acidotic. So respiratory acidosis largely occurs in these patients when they cannot remove enough of that CO2, making their blood more acidic. Now, when you're doing your respiratory assessment on them and you're noticing that they're in respiratory acidosis, some of those clinical manifestations are going to include confusion, easy fatigue, lethargy, shortness of breath, and even sleepiness as it progresses into more dangerous. So if a patient starts to become sleepy and fatigued, that's really something that we want to grab the provider on, because that one's becoming a medical emergency. Here we have a couple pictures of clubbing, one in the early stage, middle, and severe. So clubbing is a classic sign of COPD, and it's a sign of long-term oxygen deprivation. So clubbing initially manifests itself as like a sponginess in the nail bed, along with loss of the nail bed angle, causing the nail to curve downwards. So it'll start out slight sponginess, and you'll see a slight curve to it. But as the chronic hypoxia continues, then you're going to get more and more and more pronounced. So even you can see it on the picture of the actual person on the right side of the slide here, and I'll tell you that is a very classic and common sign of clubbing in patients. Now, when these patients come in exacerbation, you may also see some blue tint to the nail beds, indicating increased hypoxia, that we really need to give them additional supplemental oxygen. Now let's talk about the second class of COPD, which is emphysema. So in emphysema, impaired oxygen and carbon dioxide exchange results from destruction of the walls of overdistended alveoli. You can really see from these pictures here as well. So emphysema is a pathologic term that describes an abnormal distension of air spaces and destructions to the walls of the lung. This causes an increase in dead space. So that's an area of the lung where no gas exchange can occur, and impaired oxygen diffusion, which leads to hypoxemia. In later stages of the disease, carbon dioxide elimination is impaired, resulting in hypercapnia, which is increased carbon dioxide tension in arterial blood, leading to respiratory acidosis. So you can see here, as emphysema worsens, you just lose alveoli within the lungs, which is essentially just non-working lung space. As with the blue bloater, we also have a picture for our emphysema patients, and that is the pink puffer. So in these patients, they're going to be a lot thinner. You're going to have increased CO2 retention, which is going to cause them to be pink, which is where you get the pink puffer. They are not cyanotic like they are in chronic bronchitis. These are the patients who are going to be taught how to do the pursed lip breathing, which we'll show you a little bit later. They do have an increased mucus production, ineffective cough though, so they are not very successful in moving that mucus. The bronchi collapse on expiration, So you're really not keeping very strong lung space open when the patient's breathing out. They're going to have a barrel chest, shortness of breath. They're also going to experience the exertional dyspnea, so it's going to be very difficult for them to do any ADLs. They become very easily fatigued. You'll hear wheezing in these patients. They're not going to be able to speak in full sentences. Now, this is also a very good indication for a patient that's in a COPD exacerbation. If they're normally able to speak in full sentences, but now they're speaking in just short, abrupt phrases because it takes too much breath to speak in a full sentence, that's when you know that they need some sort of treatment. These patients are going to be very anxious. They have frequent upper respiratory infections, prolonged expiration time. They also use their accessory muscles. In fact, because of how thin they are in nature, their use of accessory muscles is going to be far more obvious than in the blue boater. And then this also can lead to right-sided heart failure or the cor pulmonale. This is a really good picture of an emphysema patient who is using accessory muscles to breathe. You can see in a normal person, you should not be able to see all three of these different muscular areas just in breathing usage. Here we have a person sitting in a tripod position, which is a classic sign of an emphysema patient. So first you'll notice the barrel chest, thin they are in appearance, and pink. So we've got our pink puffer sitting right here, okay? They're also leaning forward and using accessory muscles to breathe. This is called the tripod position and is also very, very common. You may see it too sometimes in children who are finding difficulty to breathe, but in adults, it's most commonly seen in COPD patients. Here we have a chest x-ray of a patient with emphysema. So we just kind of want to show you what the barrel chest looks like on a chest x-ray. You can see that chronic hyperinflation and loss of elasticity due to just the flattened diaphragm there, and then increased lung volume. There's far more room and open space in there than there would be on a healthy, normal set of lungs. This is a little mnemonic just to help with nursing management of our COPD patients. So in C, we want to check on the patient. We want to check their O2 saturation, their level of work of breathing, and their breath sounds, their vitals, any of their labs. We want to do a full assessment, skin color, sputum color, consistency. Never leave these patients alone, especially if they're experiencing some sort of respiratory distress. This is probably where you call a rapid response. so that you can make sure that you get an RT and maybe a physician at bedside. All right, these patients also need oxygen delivery. So administer oxygen per orders. Do we need any coughing education, suctioning to remove any secretions? Maybe they've got a mucus plug that's stuck, deep breathing techniques, and then an incentive spirometer can even help in these patients. Positioning. These patients should not be laying flat. That makes it much more difficult to breathe. So put them in high Fowlers or allow them to sit in a tripod position if that's more comfortable for them. And then even drug therapy. So these patients absolutely are going to require breathing treatments, bronchodilators, anti-inflammatories, and then also mucolytics to help to control all of that mucus production. One of the ways that we can diagnose patients with COPD is by using a pulmonary function test. So this test is used to evaluate the airflow obstruction and to determine a patient's disease severity and then also monitor its progression. Remember, in patients with COPD, once you develop COPD, there's no reversing it, there's only slowing down its progression. So these pulmonary function tests are very important to help diagnose, but they're not the only way that you can assess or classify COPD. So pulmonary function in general is going to be evaluated in conjunction with other symptoms, including your health status impairment with COPD and the potential for exacerbation. So what makes it worse? Factors that determine the clinical course and survival of patients with COPD include history of cigarette smoking, exposure to secondhand smoke, age, rate of decline of the forced expiratory volume, hypoxemia, pulmonary artery pressure, resting heart rate, weight loss, and then the reversibility of airflow obstruction and comorbidities. So there's really a large number of things that are going to contribute to the diagnosis and management of a patient with COPD. And for good reason, there is an entire specialty, pulmonology, that is dedicated to managing patients like this with COPD, because it is something that takes a look at a lot of different avenues and a lot of different treatment methods. It's very individualized on each patient. One way that we can measure a patient's severity in COPD is by checking an arterial blood gas. So an arterial blood gas measures the acidity, or the pH, and the levels of oxygen and carbon dioxide in the blood taken from an artery. This test is used to find out how well the lungs are able to move oxygen into the blood and then remove carbon dioxide from the blood. So an ABG gives a very good indication of how severe a patient's COPD has progressed. Now, in an exacerbation, this may be worse and may also be used as a tool to help diagnose COPD exacerbation and to monitor whether or not the treatments that we're giving that patient are working. Here I'm going to walk you through just a couple problems for ABG interpretation. There is a tic-tac-toe exercise if you've used that method before on Canvas to practice with. Otherwise, this shouldn't be all that different from what you experienced with Dr. Medina a couple quarters ago in Patho. And you are going to see stuff like this on your exam. It may not be as simple as this. It may be integrated into a word problem in describing a patient. But overall, I did want to kind of just walk you through how to do each one of these. So the first step that I want you to look at when looking at a patient pH or an ABG is I want you to look at their pH level. So in order to interpret whether or not these are high or low, you need to know the different levels of pH, PaCO2, and then HCO3, which is bicarb, and carbon dioxide. So a normal level for pH is going to be 7.35 to 7.45. A normal value for PCO2 is going to be 35 to 45. And then a normal bicarb level is going to be 22 to 26. So when you're also doing this, I also want you to think, when you are referring to CO2, I want you to think about the lungs. I want you to think respiratory. When you are referring to bicarb, I want you to think about metabolic, and I want you to think about kidneys, okay? So metabolic, kidneys, HCO3, bicarb, respiratory, lungs, CO2, carbon dioxide, okay? Keep all of those in mind. So when we're looking at the first problem, we've got a pH of 7.27, which we already know means that the patient is acidotic, right? So now we need to figure out where is that coming from. So CO2, the higher the CO2, the more acidotic the patient is, right? The lower the CO2, the less acidotic. And then when we go to bicarb, the higher the bicarb level, the higher the pH will be and alkalotic, and then the lower the bicarb, the less alkalotic the patient will be, okay? So if the patient is acidotic, the first thing we want to look at is to see whether or not the PCO2 or the carbon dioxide is elevated. In the first one, it is not. So in fact, the carbon dioxide is lower than normal range, which should actually make it more alkalotic. So it doesn't look like the lungs are what's contributing to the acidosis. So now let's look over at the bicarb. The bicarb is 15, which is far lower than its normal range. So the lower the bicarb goes, the more acidotic the patient will become, right? So if the patient is acidotic and the bicarb is low, then it's safe to say that the patient is in metabolic acidosis, right? So now we also can't forget about the PaCO2. So is the carbon dioxide, are the lungs doing what they're supposed to do? Well, they're trying, right? They're lower. They've lowered themselves below their normal rate in order to try to compensate for the fact that the kidneys are very, very low right now from their normal range. By doing that, they've tried, but they have not been able to fully compensate. So if they cannot fully compensate the pH, which fully compensation means that it would be within a normal rate, then we are looking at a partially compensated metabolic acidosis. Now let's look at number 2. The pH is 7.34, which isn't quite in normal range. It's close, but it's not quite in normal range. It's acidotic. So if the patient is acidotic, now we need to find out where is the acidosis coming from. So let's check on the PCO2 or the lungs, and it looks like that is elevated, given the fact that the lungs are supposed to be between 35 and 45, and that's elevated. We know that when the CO2 gets higher, the patient gets more acidotic. So we have a good feeling here that more than likely the patient's in respiratory acidosis, but let's double check on the kidneys. When we go and look at the kidneys are at 26. Now we know that the bicarb level, the normal kidney level, is 22 to 26. So it's not elevated, it's not decreased, it's within normal level. So it's safe to say that the patient is in respiratory acidosis because the kidneys are not contributing, nor are they hurting the patient. But are they helping the patient? The fact that the kidneys are within normal level puts them at uncompensated respiratory acidosis. Number 3, pH is 7.47, which is not within normal limits. In fact, the patient is alkalotic. So let's see where the alkalosis is coming from. When we look at the lungs, the level is 54, which is much higher than what the normal range of 35 to 45 is, which means that the lungs are attempting to become more acidotic. So if the lungs are trying to become more acidotic, then they definitely aren't contributing to the alkalosis that the body is currently experiencing. So now let's look at the kidneys. The kidneys, normal range of 22 to 26, are far outside that normal range. But we know that when the bicarb is elevated, the patient becomes more alkalotic. So given the fact that the patient's body pH is alkalosis, then this is more than likely coming from the kidneys, giving us metabolic alkalosis. Now, let's go back and look at the lungs. Are the lungs attempting to bring the body pH down by increasing to make it more acidotic? Yes, it's 9 points higher than its normal limit. So there's partial compensation, but it's still in metabolic alkalosis. And the final question we have here is the pH is 7.36, which is within normal limits. So how do we determine if there's acidosis or alkalosis? Well, the first thing is you want to see, is it within normal limits but leaning towards acidosis or leaning towards alkalosis? In this case, it's only 2 points away from being acidotic. So we're going to lean towards this patient possibly being acidotic. Now let's go over and look at the lungs. The CO2 is elevated at 80, which we know is far higher than what it needs to be, putting off much more acidosis than normal. So that's a good chance that's where it's coming from. But let's look at the kidneys. When you look at the kidneys, the bicarb is at 44, which is also far higher than what you expect it to be. Now, we know that when the bicarb is elevated, that leans more towards alkalosis. So given that this patient is closer to acidosis, it's more likely that this patient is experiencing a respiratory acidosis given the high CO2 level. Now, because the patient is actually within normal limits, that means that the bicarb was able to step in and help compensate for what the lungs were doing, which gives us compensated respiratory acidosis. Now, in very rare cases, patients can be diagnosed at an early age with COPD due to alpha-1 antitrypsin deficiency, or AAT deficiency, which is an inherited condition that raises your risk for lung and liver disease. So alpha-1 antitrypsin, ATT, is a protein that protects the lungs. The liver makes it. If the ATT proteins aren't in the right shape, then they'll get stuck in the liver and they can never reach the lungs. Like I said, this is very rare, does not happen. I've never seen it in my own practice, but it is a possibility that's out there, especially if you have a patient who's younger than 45 years of age and they're being diagnosed with COPD. Now, in patients who have been diagnosed with the alpha 1 antitrypsin deficiency, there are a couple of different ways that we can treat these patients. Okay, the first one is augmentation therapy. And this is when doctors increase your AAT level with donated alpha 1 antitrypsin. So if you have emphysema due to alpha 1, augmentation therapy may be considered, and you may be recommended to receive weekly or monthly infusions. And those are injected into a vein. This treatment may continue for the rest of your life. Another one is going to be a lung transplant. A new healthy lung from a lung transplant can help relieve some of these respiratory issues. Medications, steroids, other drugs called bronchodilators can help make it easy for you to breathe by opening the airways in the lungs. Oxygen therapy through a mask or a tube in the nostrils can help to breathe more comfortably. And then also pulmonary rehabilitation. So exercises, behavioral changes can relieve breathing problems to improve your daily function, slow down the progression, and then it also allows you to do more with your lung function than you otherwise would be able to. So again, this deficiency isn't super common. It only occurs in about 1 in every 3,500 patients in the US. However, it's also not very well recognized and is underdiagnosed, so that number may not be as accurate as we think. Now, for patients with stable COPD, treatment aims are to reduce the risk and symptoms. The major risk factors associated with COPD are environmental exposures, and that is very modifiable. So the most important environmental exposure that can be modified is smoking. Because multiple factors are associated with continuing smoking, successful cessation often requires multiple strategies. Referral to a smoking cessation program may be helpful. Nicotine replacement is a first-line pharmacological therapy that reliably increases long-term smoking abstinence rates. This comes in so many forms, so you can talk to your patient about what works best for them, whether that be gum, an inhaler, nasal spray, transdermal patch, sublingual tablet, or even a lozenge. Okay. These patients also should be educated on the importance of staying on top of their immunizations. So influenza, pneumonia, even patients now for COVID-19, they're being very educated on why that's important for them to get their boosters. And that has to do with the fact that these patients are at such higher risk for infection that they really need those immunizations to give them all the chance that they can get. This is a visual representation and a chart, because we love those, to just show you what might be implemented at what stage of COPD, the different therapies that might be included, and how they're going to diagnose and stage each level of COPD. You do not need to memorize this chart. It's just best to know that if your patient is on multiple inhalers or has a forced expiratory volume of less than 70, that they are far more progressed within their COPD than those with someone who might not be. Most all patients with COPD at some point will be on a metered dose inhaler for medication treatment. So, attention to effective drug delivery and training in proper inhalation technique is essential when using a metered dose inhaler. A respiratory therapist is actually really, really helpful in training. If you are unsure, it's always good to check with them because they know how to do that very well. But it is very important that you make sure that you educate your patient on properly how to use the metered dose inhaler. Otherwise, they won't be getting the amount of medication that they need. Because of the significant relationship between poor inhaler technique and the lack of symptom control, issues that could affect proper inhaler use must be considered when assessing the effectiveness of these medications. So conditions such as decreased hand inhalation coordination, insufficient hand strength, so they're not able to hold the inhaler, and the inability to generate a sufficient inspiratory flow could impair the delivery of the medication and impair the whole system. So if they are unable to properly hold the inhaler, properly hold their breath in order to take in all the medication, a spacer might be very useful for these patients as it allows them something larger to hold on to and will contain the medication within the spacer so that the patient can take multiple breaths to try to take in all of the medication. Now, we want to be very careful with oxygen therapy in management of COPD patients. The goal of oxygen therapy is to provide adequate transport of oxygen in the blood while decreasing the work of breathing and reducing stress on the heart. A change in the patient's respiratory rate or pattern may be one of the earliest indicators of the need for oxygen therapy. These changes may result from hypoxemia or hypoxia. Now remember, oxygen is a medication and except for emergent situations, it is only to be given when prescribed by a healthcare provider. As with any other medication, the nurse administers oxygen with caution and carefully assesses its effects on each patient. Now, especially with COPD patients, these are the ones that you need to be more cautious about throwing on 2 liters of oxygen without a doctor's order. Okay? In COPD patients, administering too much oxygen can result in the retention of carbon dioxide. The high O2 levels can then suppress CO2 chemoreceptors, which in turn would depress the respiratory drive and disrupt ventilation perfusion balance. So in COPD patients, the increased CO2 levels are what are driving the patient to breathe. So we don't want to over-oxygenate them and take away their drive to breathe. Here we list a couple of terms and complications when referring to COPD patients. So hypoxemia is low to oxygenation saturation in the blood. Okay, oxygen therapy, removal of secretions and medications can help improve this. Hypercapnia is CO2 retention. So when that happens, you're going to get that increased drowsiness or confusion. Pursed lip breathing and mechanical ventilation can help improve this. Although we do want to be very hesitant with COPD patients and intubation because they can be much more difficult for them to get off the ventilator than someone without COPD. Respiratory infections, oxygen therapy, antibiotics, infection preventions, and immunizations are all absolutely necessary given that these patients are at much higher risk for infection. And then we've got the right-sided heart failure, so the cor pulmonale, which will leave us with some dependent edema, those distended neck veins, shortness of breath. Cardiac monitoring, diuretics, these are all really helpful. And then trying to lessen and decrease the things that are actually leading to the cor pulmonale. Pulmonary rehabilitation is one of the most cost-effective treatment strategies. It's a holistic intervention aimed at improving physical and psychological health of patients with COPD. The primary goal of pulmonary rehabilitation is to help reduce symptoms while improving the quality of life and increasing physical and emotional participation in everyday activities. Other treatment options include medications that can be used to reduce smoking and improve quality of life, such as antidepressants, which may increase long-term quit rates. Other pharmacological agents include like antihypertensive medications like clonidine, although you have to be very careful with its side effect use because it definitely can lower the blood pressure quite a bit. So we want to make sure that it's appropriate for the patient. Now remember, nurses can be instrumental in educating patients and families, as well as facilitating specific services such as respiratory therapy education, physical therapy for exercise and breathing retraining, occupational therapy for conserving energy during activities, in order to help them with their daily living. Also, never forget about nutritional counseling, as that can also help with these patients and their quality of life. So these patients need to be encouraged to be active as they're comfortable, exercise as much as they can, and what that is within their tolerability level. One of the things that we can do as nurses in some of our patient education are breathing exercises, or also known as breathing retraining. And this consists of exercises and practices that are designated and designed to achieve more efficient and controlled ventilation and to decrease their work of breathing. Now, in these patients, one of the techniques is called pursed lip breathing. And this helps to slow a patient's expiration, preventing collapse of small airways, helping to keep the alveoli open, and it helps the patient control the rate and depth of their respirations. This is just a picture representation of what it looks like for a patient without pursed lip breathing and then a patient with pursed lip breathing. You can see how much more open the airways, even all the way down to the alveoli, are in the pursed lip breathing than the non-lip breathing. Now, nutritional assessment and counseling are very important in patients with COPD. Nutritional status is reflected in the severity of their symptoms, a degree of disability, and their prognosis. So, significant weight loss is often a major problem in patients with COPD. However, excessive weight gain can also be problematic. But that occurs far less than the significant weight loss. So you really just, it's very case by case basis. Most patients with COPD actually have difficulty gaining and maintaining weight. So high protein diets, high calorie diets, they need that energy because they've got that constant increased work of breathing. In the absence of any sort of heart failure, we want to increase their fluid intake because that hydration will help break up that mucus secretion, and then teaching them on how to use the bronchodilator before they eat if they're having difficulty while eating. Now, again, it is important that these patients are drinking the appropriate amount of water for them. In the absence of heart failure, they need to be drinking 2 to 3 liters per day, which is a good amount of water. You want to encourage that liquid between meals and stress to them the importance of why they need to stay hydrated to help break up that mucus so that they can move it, and it will actually help them breathe better. Most of this secondary prevention is going to be to help prevent their disease process from progressing as quickly. So you're going to want to teach on why prevention of infection is important, those breathing exercises, enhanced physical conditioning, exercising, moving. They want to aid with self-care, so taking care of themselves, removal of secretions, and then all of that, how all of that will help to improve their gas exchange and thus making them far more comfortable to be able to live their life. And now that your patient is being discharged from the hospital, we want to focus on their COPD home care needs. So remember, the main emphasis of home care is on determining the patient's understanding of the treatment plan and how well it's being carried out. Remember, this disease process cannot be reversed, it can only be slowed. So if a patient doesn't fully understand the treatment plan set up for them and how to carry it out, then they are going to progress more rapidly. So it's very important that we as nurses make sure that they truly understand their proper treatment plan. Do they have all the equipment that they need? Do they have a spacer for their inhaler? Do they have home oxygen if it's necessary? Medication administration, making sure they understand the importance of taking their medication or to take their oxygen at night. Protection from infection and ultimately respiratory failure, how infection can actually lead towards their quicker decline. And then instruct the patient or the caretaker on when is important to call the physician. Are you starting to cough more than normal? Do you feel more short of breath than normal? Are you not able to speak in full sentences anymore? Or now when you walk from one side of the house to the other, you get short of breath? Any new onset symptom, it's time to reach out to the physician and speak to them and maybe get some more testing to see if you're having some form of exacerbation. So that concludes our lecture on COPD. If you have any questions, please feel free to email me for clarification, and have a wonderful holiday.